So my current focus is on looking at clinical outcome studies from looking retrospectively post-surgery as how patients do to partnering with industries to look at new technologies, new techniques. Specifically, we've been working on looking at integrated cages. That's what most of my research has been on. And we focus on how different implants, so spacers for intervertebral or vertebral implants, make a difference for corpectomies. Using integrated cages, that means traditionally we've been using plates and cage systems. And now we're using more of both integrated into one. So spacer plus the cage, and we're studying how screw systems, do you need 2 screws, 3 screws, or 4 screws, makes a difference in patient and biomechanically in a lab, and how does it translate into a clinical model? Does that how do patients do with this kind of cages? So we're looking at 1-year, 2-year outcome data at this point. We're also looking at new techniques such as the anti-psoas approach. So that's something we brought to UC Davis from around the country that's been going on. We're looking at how doing minimal invasive surgeries or approaches where it used to be done open approaches, patients were in the hospital almost 2 to 3 days longer. We have cut down length of stay time with them, and they're up and walking around the next day, allowing us to do much more complex surgeries in a smaller approach, minimizing length of stay, blood loss, tissue trauma, radiation rates. So it's been very important for us. Currently we have a trial looking at new technology for how we put in our screws. We're looking at how navigation makes a big difference compared to a monitored probe. Traditionally, we used to use a probe to create a track to the pedicle, but now there is navigation allowing us to bring ease to how we put in our screws. Now we're comparing that to, does a monitoring probe make a difference? And is there safety to these techniques? Currently, we're having that trial. This mostly is for, at least from the technique perspective, can be applied to any patients. It could be for tumor patients, it could be for degenerative spine. That's what most of our practice is based on. 50 to 60% what we see is degenerative spine. But now with the recent use of multiple fusion devices, now we'll see a whole group of patients with adjacent segment disease. That's the new thing we'll notice. Most patients, more primary care doctors will see coming back with problems at the levels above and below where they had surgery. I think it's a little bit of both. I think with minimally invasive approaches, you're preventing adjacent disrupt tissue trauma. So the idea is to, if you avoid tissue trauma, are we avoiding causing problems at adjacent levels? So the idea is to, as a surgeon, you want to get somewhere without disturbing as much tissue as possible. But the surgery itself stays the same. We don't really change the technique of what the surgery requires us to do, which has been there for years, but how we get there has changed. And it's really impacted our clinical outcomes. I think it depends on, because it's a degenerative process, so there's no way of gauging that. That's why we're studying, does MIS make a difference? In certain areas it seems to affect it, in certain it doesn't. But you have to remember, spine surgery is not a cure, it's a treatment for spine. So most patients will degenerate. As long as you're degenerating, you're going to have a problem somewhere else, and eventually you'll end up needing more surgery based on your lifestyle. Your genes seems to play a role as well. For degenerative spine, it's kind of hard to predict because you'll see patients who have really bad imaging, but clinically they're asymptomatic. I routinely tell my patients that my spine probably looks worse than yours because I'm on my feet all the time. But it depends. What we try to treat is patient to see what they're coming in, what kind of symptoms they have, and if they really need surgery. Most of the time we operate is for progressive neurological deficits, and that's what we're looking for in patients before we consider any kind of surgical intervention. The way to measure newer approaches is based on, there's a number of ways. One is just raw data from the OR. We look at blood loss, surgical time. We look at how much radiation are you utilizing or needing to use to do this procedure. From a clinical outcomes part, we have surveys there, validated surveys we use to see what patients are experiencing. So it's patient-reported surveys. They're not from surgeons saying they did great. It's actually patients reporting themselves how they did, and we share that with them and compare it and see how they feel. We also have, it's not just about the surgery, it also becomes about experience. How are they, is their hospital experience was great or not? So did they have less pain throughout the hospital stay? Is their recovery was quicker or not? So there's multifactorials that goes into place. I think it's becoming a growing trend. You'll see evidence-based practice, but special focus on clinical outcomes. I think that's because where the CMS is taking us, it's going to be quality payment programs that are coming out. So you'll see surgeons, we're transitioning from fee-for-service models to value-based models. So what we're seeing is that surgeons and hospitals are teaming up, especially at UC Davis. We're looking at how length of stay is, readmission rates are, return to OR rates are, as well as postoperative complications such as TVTs, UTIs, postoperative pneumonias. So I think that's what you'll see working together as a team trying to make a difference. So the idea is to offer them some kind of solution. Here we kind of have a multidisciplinary approach where in our spine center we have from acupuncturists to we have physical therapy, occupational therapy, we have pain physicians, we have rehab physicians, we have orthopedic and neurosurgery spine surgeons. So we kind of offer what the patient, we kind of specify a plan based on what patient has and what their needs are and what they want to get out of the experience or care. There is something to offer to everybody from different disciplines. There is always something that we could do for you. It may not be 100%, but there is always something we could offer.